All right, everybody. Thank you for joining us on Heart Talk this evening. If you've been here before, welcome back. If you haven't, welcome. We have a couple of really special guests joining us this evening. I know that we've kind of been ramping it up, and I'm excited that the time is finally here for us to have this conversation. I'm sorry. Dr. Lopez is somebody that we met in Houston when we attended an ACHD event back in February. And so one of the things that I know Crystal and I have touched on in our previous sessions is that conquering CHD covers a lifespan. For Crystal and I, we have little ones. And something that Dr. Lopez covers is transitioning out of pediatrics into adult care. So we have Dr. Keila Lopez with us, and then we have Jennifer Weiner, who is from our national part of Conquering CHD. She runs our ACHD coordinator position. So we have two really amazing ladies joining us this evening, and I'm going to pass it over to them. Dr. Lopez, if you'd like to say a little bit.
Hello, thank you so much for the opportunity to come and speak with the group this evening. So my name is Keila Lopez. I am a pediatric cardiologist at Texas Children's Hospital in Houston. I joke around that I'm a public health person who happens to be a pediatric cardiologist. And so I do a lot of work in public health and public health safety. And one of those things is recognizing when different groups are disproportionately affected or have some health disparities. And so I viewed the space of transition as a health disparity, an area where there was not a lot of work that was being done to help prepare teenagers to become better adults with congenital heart disease. And given that they are living longer and that congenital heart disease is the most common birth defect, we thought, we really better improve this space, particularly given that there's not a ton of adult congenital heart disease providers yet. And so we just viewed it as a way to reduce, or I viewed it as a way to reduce health disparities, and started a program at Texas Children's to try to inform that space, as well as I have an NIH grant to do mobile application to help in this process as well.
Fantastic.
Jen?
Thank you so much.
Hi, I'm Jen Weiner. As Haley mentioned, I'm the Adult Congenital Heart Disease Coordinator for Conquering CHD's national organization. I'm also an adult with congenital heart disease. I'm 38 now, and I was born with truncus arteriosus. I'm currently followed in the ACHD clinic at Lurie Children's in Chicago.
All right, guys, thank you so much for introducing yourselves. We really appreciate it. As always, you guys, I want to let you know, if you see me looking up, I am looking at questions. We're always watching the comments. If you guys have any questions as we go, please feel free to drop them. We have a pretty tight agenda this evening. Dr. Lopez has a lot to share with us, and we have a lot of questions for her. So if we don't get to your question this evening, we will make sure to loop back and answer it later on. Just know we're not ignoring you. So I think we should go ahead and jump in. Crystal, if you want to take it away.
Absolutely. Dr. Lopez, can you kind of just start now, tell us a little bit about the transition process from pediatrics to adulthood, and what kind of coupled with that, what skills are going to be important for people to learn when they're in that transition period?
So I like the term transition process, because it is a process. So a lot of people think transition is when you move from the pediatric provider to the adult provider, and that's not the case. So I'd like to make first of all a distinction between transition and transfer of care. So transition is when you shift the responsibility of healthcare management from the parent, to the patient or to the teenager. So that's a shift in care from one to the other, and that's a pretty hard thing for both people because it's a new way of being. Yeah. And then the transfer of care is the actual movement from the pediatric system or a pediatric provider to an adult system or an adult provider. So you're transferring from one system or one provider to another. Okay. So transferring care is something that is much quicker, because once you go from pediatric to adult, it's done. But the transition process is what prepares you for that transfer of care. And if you're not appropriately transitioned, or you don't have the appropriate training to transition, the transfer doesn't tend to go as well. And a lot of people don't actually even make it to the other side if the transition process is not done appropriately. So the transition requires a lot of different things. A lot of people think, oh, that just means that you need to know what you have. Okay, that's great. As a matter of fact, it's much, much more than that. It requires knowledge of your disease. It requires knowledge of what surgeries you've had. And so knowledge is one piece of it, what medications you're on, why you're taking them, etc. But the other part of that is skills. So for a long time, your parents have been taking care of you, and your parents have been the primary decision makers for your condition and for your care, because you were born with this condition. And so it's natural for you to defer to your parents and be like, well, what are we doing now? Or to defer to the doctor and be like, well, what are we doing now? So it actually, the skills that are required are things like understanding and learning how to advocate for yourself, understanding how to ask the doctor questions, understanding what questions are important, understanding how to make your own appointments, how to take your own medications, how to refill those, understanding about insurance and why does it matter, and understanding about more complex issues like advanced directives and things. These are all skills that we teach in the transition process. And it's stuff that you don't know that you're supposed to know. You just, no one really tells you how to do this. And so no one tells you how to do it when you're a regular teenager, let alone when you're a teenager with congenital heart disease. And so it's more important for them to actually learn specific skills that they need to do and know to be successful adults with congenital heart disease.
Oh, I love that. I love the distinction between transition and transfer. Thank you for sharing that. That's definitely, I think moving forward, I'm definitely gonna be more mindful of my wording.
Yeah, definitely.
So is there an age that patients should begin to transfer or to transition? And is there a certain time that, we know that they're ready to do that?
So this is a super controversial question. A lot of people have different opinions on the answer to this question. And so honestly, there are different countries do it differently, different programs do it differently. And I guess the answer is trying to have a process is better than having no process, regardless of when it starts. And so in Canada, they had a GOT transition program that was a national program. And they had that at Sick Kids in Toronto, which is one of the primary heart centers in Canada. And they started at 12 years old. There are other places that start mid-teenage years in other countries. And so what I think is important in terms of when do you start this is, before you jump right into this whole transition business, is preparing the family to say, just so you know, congenital heart disease requires lifelong care. And in order for you to receive lifelong care, that requires your teenager to then know how to be an adult with this chronic condition. And so in order to do that, we are going to prepare them by putting them through a transition process, or they need to go through a transition process to kind of morph themselves into the adults that they hope to be their best self when they're adults with congenital heart disease. And so there's one other thing to consider, and this is actually fascinating. People used to think that teenagehood ended at 18. And I guess technically speaking, teenageness ends at 20 because the word, teen doesn't apply to a 20-year-old. But there's lots of data that shows that there's lots of data that shows that the adolescent brain is not fully mature until teenagers are into their mid-20s. So there are actually some countries that, including Australia, that have extended adolescence until 26. Because brains are not fully developed. Your executive functioning in your frontal lobe is the last part of your brain to develop, and it's not fully developed until you're 26. And so that process is even more delayed if you have congenital heart disease, or the significant congenital heart disease where your brain saw blue blood or deoxygenated blood while you were in utero and for some significant period of your life. And so knowing that, you have to kind of meet the patient where they're at in terms of transition. You can't kind of do this cookie cutter business where it's a one size fits all. And so we've seen in our program at Texas Children's, we've seen over 1,000 teenagers. And we have found that for us, introducing the program too early, people freak out and don't like it and feel very intimidated by this. And how dare you tell me that I can't take care of my child anymore? So we have found that at 14, introducing the program at 14 and then starting the program in earnest at 15 works really well for us, because then we can prepare the kids and their families. And then one other thing I'd like to mention, there's a lot of work surrounding what do teenagers know or not know. And so a lot of times they get a survey, right, to fill out. And it turns out that this is probably not going to surprise those of you who have teenagers. A lot of teenagers think they know more than they actually know. And so they'll fill out the survey saying, yep, I know that, I know that, I know that. When in actuality, if you ask them, hey, do you know this? Can you tell me more about this? They don't actually know the data. And so, or the information that they're supposed to know or the skills they're supposed to have. And so we do something called motivational interviewing, where we will take them through their survey of knowledge and of skills and say, tell me more about that. And if they can't express or explain, and they just checked yes so that we would get off their back, we dive in and understand better and teach them better how to know what they're supposed to know and how to know what they really know. And so the bottom line is engaging the teenager in their care by doing motivational interviewing, by saying, I have an individualized learning plan for you. This is your plan. This is what we're going to focus on for you because you have this heart lesion and this is where you are, which is what we do. And then targeting deficiencies so that the teenager isn't learning stuff that they already know, we found that to be extremely helpful so that teenagers become more engaged and activated in their own health care. Last thing I'll say, we developed a tool, which I promise that one day we'll publish. I promise. We're trying. That is the chat tool, the Congenital Heart Health Activation Transition tool. And it's a tool that we use in our clinic that has a red, yellow, and green section. And in the red section, it's, this is critical. You need to know this for your safety. The yellow stuff is important, not as critical, but important things like medication, side effects, activities that you're restricted from, etc. And then the green portion is kind of lifelong care. So it's like a, red, yellow, and green. And once you hit the green portion and know the green section, which is your lifelong care and your trajectory, then we say, you know what, they were able to walk through this. They were able to teach back to their parents. And we think that means that they're probably ready to be closing to transfer care to an adult provider.
Wow.
Long answer to your question, but
no, I think something that we all kind of discussed before we had you on was that listening to you even back at the event in February, everything that you say, we just kind of absorb. And I was going to say, Crystal and I are dangerous people to promise things to because we will be following up with you about that. That is really cool. That's awesome. Jim, I'm going to pass it over to you.
Sure. Dr. Lopez, you mentioned that a lot of patients don't make it through the transition process. Which populations tend to have the most trouble making it through transition and transfer of care, and why might that be?
Well, certainly if you don't have a transition program, that's going to make it harder for you to make it through transition. I will tell you that before we had this program, we did this not so well. We didn't ask questions about, as we term in transition, sex, drugs, and rock and roll, because people are not comfortable doing that, which is a disservice really to adolescents with congenital heart disease and young adults. And so if you don't have a program, finding other resources to help you is one major way to help individuals move along in the transition process. There's a website called I Heart Change, which helps a lot with this process. And I'm in the middle of developing an app for the transition process. It's been a little more challenging lately. There's some other things, healthcare things happening in America, but we're hoping to have that ready by 2021 as a tool. Other individuals that have challenges transitioning are those that have challenges with access to care. If you have challenges with access to care and that your insurance isn't stable, or you're not able to make your appointments because you have other things that preclude your care, like your parents can't take off of work and things like that, individuals that are of lower socioeconomic status, and many of those individuals that are in minority communities, people who have parents who have English as a second language often have a harder time with this. And so there are some communities that are a little more at risk, but hopefully as transition becomes more vital, is recognized as vital to this process, those individuals in those communities will be more focused on to be able to help them along.
That's awesome. I'm loving all of the apps. I'm very excited. I can't wait to see them.
So you should get excited in 2021. Get excited in 2021.
I'm going to stay excited.
Remember, Haley. next year.
Yeah.
So Jennifer, I have a question for you. So as you moved into your teen years and began to understand your condition, did you feel comfortable asking questions and kind of taking over your own care?
Well, at the beginning, there certainly were topics or questions that I was uncomfortable talking about, either out of fear of being embarrassed or saying something to get in trouble in front of my parents, or worrying about sounding dumb. So it definitely took a lot of practice getting used to talking to my doctors. It took some time to learn that I could trust my team. Sometimes I found that, emailing them either before or after appointments was a helpful way to start a difficult conversation that I might not have been comfortable bringing up in person. But I was really fortunate that my mom had always been forthcoming with me about my condition. It's something that we had talked about from a very young age. Like, I don't remember a time not knowing the name of my own defect. And she always included me in the conversations and talked to me about, the decisions that needed to be made. So she does still come to appointments on occasion as a second set of ears, but but it's definitely something that I'm comfortable managing on my own day to day, and scheduling my visits and leading the conversation, knowing the answers to the questions I'm asked in return.
Good.
Yeah. What was your experience like going from like the pediatric care to building new relationships with like new doctors, new just in general parent or patient, like provider relationships? I'd imagine, I know I have a hard time with change. So what was that like?
It was hard. Yeah, it was definitely hard. When I was growing up, there was no such thing as transition, and the board certification for adult congenital specialists didn't come about until I was 33. So I had seen my pediatric cardiologist until I was 30 years old. So my transition was I shouldn't even call it a transition. It was more just a transfer of care, because it was very abrupt. He said, "I'm about to retire. You need to start being an adult congenital doctor." Yeah, so that was like the last appointment I had with him. The next one I had the following year, I saw an ACHD doctor at Loyola, and that was my introduction to adult congenital care. So it took time to get comfortable with my specialists, especially because being with the same doctor for 30 years he was part of my family. So it was difficult to adjust to. But the doctors that I saw were very helpful. They set the tone by allowing me to answer questions, being very upfront with me as well, and treating me like an adult, allowing me to learn things and ask questions in my own time and make decisions for myself. So I am very happy with my team now, but it was definitely a scary kind of process.
I can't imagine if Rowan's cardiologist just up and said, "Hey, I'm leaving," I would be like, "You can't. You're not allowed."
No, it was really hard.
Gosh. So I know that you've been a really huge part of the ACHD resources that we've put together, and like the new kit that we've come out with and different things like that. And so for the viewers that we have that haven't been able to see that yet, what are like the tips and tricks that you use and have kind of helped the organization implement on just like keeping track and understanding your medical history?
Well, the first thing I would say is that it's really important to ask a lot of questions, and that you don't have to feel like you're not allowed to ask questions about things you don't understand. No one should make you feel like you can't ask, especially it's about you, it's about your care. So ask a lot of questions and write down the answers. I would also recommend to get your records from any hospital you had care at prior to transitioning to a new doctor. If you don't understand those records, your new team could be able to help explain those to you as well, explain your history. It also might be helpful each year that passes, you request your records from the previous year. So should you ever need to change providers, you have everything with you. You don't have to ask for a huge lump of records all at once. You have them as you go along. It'll help you stay on top of maintaining them. And then I also like to take advantage of my chart. So I would ask the hospital that you're at if they use my chart or if they have another online record system that they use, because physical copies are great, but they can be cumbersome to carry back and forth to appointments.
Yeah.
So if you can put it on your phone, or if you can put it on a flash drive or something like that, it's also a really helpful way of understanding or carrying them with you, no matter what doctor you have to see.
Awesome. All right, Jen, you are up.
Okay. All right. Our parents are used to being the ones in charge of our care when we're young, but as we age, their roles begin to change. How can we assist parents and families in transitioning to a supportive role to help them in letting go some of the control of their child's care?
I assume this question is to me, right?
Yes, I'm sorry.
Okay.
We can send it to you.
Okay. So first of all, I will say that in our own program that we created here, we focused very, very, very much on the teens and their needs and what they need to know. And then at some point when we were evaluating our program, the parents were like, that is so great. What about me? And we were like, oh, that's a fascinating point. Okay. And so, in the transition process, there are several what we call stakeholders. And so parents are one of them, pediatric cardiologist, the adult congenital specialist, or an adult cardiologist, depending on your situation, the pediatrician, and then the patient and themselves. So there's 5, and the parent and the patient are 2 of those 5.
Mhm.
And so you're right. Nobody teaches parents how to do this. And it's hard enough when your child is growing up without a chronic disease, let alone with a chronic disease, to figure out how to let go and say, oh, you know what? I've been totally taking care of you for the last 14, 15 years. And now I'm just going to step back and let you take care of it. It's very, very challenging. And so parents also actually need to learn some of those skills. And so one of the biggest skills is to allow the teenager to answer the questions that the doctor is asking. And so if the doctor is asking a question and the parent jumps in because they're used to jumping in, that doesn't then allow the teenager to answer and to start to assert their own care, or their primary responsibility for their own care. Allowing them to ask questions, coming in with a game plan, like, what are you going to ask the doctor today? So that you're not intimidated to ask questions, because you like you were saying, Jennifer, it takes practice to do. And then there's something that is really quite common in adult medicine that we do less well in pediatrics for obvious reasons when you're younger, but I think is probably going to become a more significant thing for these transition aged kids, particularly those with chronic diseases as they get older. There's a model of care that's called shared decision making. And shared decision making is one where you have the key component of this is patient-centered care. And so the center of the care becomes the patient. The doctor's like the coach on the side, and the parents become the cheerleaders, is one way to think about it. And so the parents move into this supporting role where they are cheering on the independence and the empowerment of this teenager, if you will. And the only way to really do that is to help give the parents skills to sit back. And it's really hard. It is a learned skill. It is just like the teenager has to practice how to ask questions. The parent has to practice not to answer them. Yeah. And this is something that goes on over time. And so eventually the goal, and many pediatric cardiologists don't do this. The goal is to then have the teenager come to the clinic by themselves, completely by themselves, prior to transferring care. So you can see where they are, what they know, what they don't know. And certainly you can speak with the parent afterward, but it helps a lot in the teenager feeling how that feels to be in there and assert your own care and ask your own questions and having the doctor speak directly to you, which is obviously more of an adult skill.
Yeah.
So those are some ways that parents can kind of grow into this. It takes time, though. It is a process, just like the transition process is for the teens. It's a process for the parents as well.
I know my mom had some thoughts about the transition after I took over my own care. It was definitely difficult for her to sit on the sidelines and watch it, but she's gotten very used to it.
Rowan's only almost 2, and I can't even fathom not being at a cardiology appointment with her. So I think that as much as this is for our ACHD patients, I think it's also really important for parents to watch, because there's resources out there for them too, to help them also go through this process alongside them, because when you do it all of their life, okay. I'm gonna
It does get better. It gets better. It does. It starts to feel more natural with practice. It does. Most of our participants in our program have said this, which is good.
Well, I think the idea of having the teen go by themselves to an appointment, I've never heard of that, but hearing, I mean, that sounds like a wonderful idea. I wonder if a lot of offices here in Texas actually do that. I'd love to do a little research. So
Dr. Lopez, one thing, Jennifer mentioned was it was what, 33 before you transitioned to an adult program. So when, parents are starting to look at the transition process and transferring that care eventually, like, how can they distinguish what centers actually provide the appropriate care for CHD, not just a generic cardiologist, but a center that's going to provide them the appropriate care? Are there tools out there for that? Is it kind of luck of the draw? What are your thoughts?
Well, it used to be the luck of the draw, and that was a really poor way to do things. We found. So someone said, "Hey, this is a really bad way to do things," and out of that was born board certification for adult congenital heart disease, which, as Jennifer stated, it started in 2015, I believe, was the first class that actually did ACHD. And so right now in America, we have a whopping 555 adult congenital heart specialists that are board certified.
Wow.
So that is a low number. When you think of that, 40,000 patients a year or so are becoming adults with congenital heart disease. That's an estimate, of course, because we don't track them like they do in other countries. But so understanding the difference between an adult congenital specialist and an adult cardiologist is step number one. Adult cardiologists are actually not required to do training in congenital heart disease. It is optional. And the recommendation, now this is not even a requirement, the recommendation is that an adult cardiologist receive 6 hours of lecture. That's a recommendation.
That's it.
What?
That's it. Wow. And so they're not required to rotate through. Some of them do, but they're not required to. And so some of them may go through the entire training never having seen an adult congenital heart disease person. So this makes it particularly challenging for that cohort. Now, that being said, there are some diseases that we see that patients are born with in that we see as pediatric cardiologists that are kind of more bread and butter for adult cardiologists. For example, aortic valve issues, super common for them, or even mitral valve issues is very common for them. But there are more complex lesions, obviously, that are less common for them, including things like truncus arteriosus or patients who have hypoplastic left heart and are Fontan, things like this. They're much less trained to do that. So the adult Congenital Heart Association, or the ACHA, has come up with an ACHD accreditation. So in addition to seeing if that provider is ACHD board certified, the adult congenital heart disease accreditation is something that there are heart centers that are now accredited and saying you are vetted to take care of patients that have adult congenital heart disease. And as a matter of fact, part of those accreditations is transition. So there has to be some sort of a transition process in place for that accreditation.
Wow.
And how people define a transition process is highly variable. You can say, yep, we tell them it's important. They say it sounds good. And you can call that your transition process. So not all transition processes are created equal. Yeah. And so there's some work to be done in that space. But at the very least, having centers that are specialized in taking care of patients with adult congenital heart disease and having a resource for that, which is the accreditation, is hugely important. And I believe the last time I checked, there were 33 centers that were ACHD accredited. There may be, I'm sure by now there's even more because they go through cycles of accreditation. They have site visits. There's several paperwork that need to be filled out. There's interviews that are done. I mean, it's a pretty rigorous process, which is good. It should be.
Yeah.
Well, yeah.
So it's, on that topic, I just want to be clear. Pediatric cardiologists are super. I am one. I'm biased. I like us. But we are not, the majority of us are not trained in adult medicine. We did it in medical school. And may I remind you that postgraduate training is for congenital heart disease for a pediatric cardiologist is at a minimum 6 years. So it's 6 years out of adult training, of having seen an adult in med school, right? That's at a minimum. And so it's a little
Wow.
it's a little tough to ask a pediatric cardiologist to know adult issues and kind of tie them into congenital heart disease. When the two things actually are married. The two things are involved with each other, but you may not have the adult expertise to be able to do that. And so adult congenital specialists often are what we call med peds trained. So they did internal medicine and pediatrics training, and then went on to do pediatric cardiology and then do ACHD. That's a common pathway for an ACHD provider. So they have a background in adult medicine, and they are more equipped to take care of adult type issues as they age.
Wow.
Dr. Lopez, you mentioned that there's only 500, just over 500 adult congenital specialists in the country. A lot of other adult patients mentioned to me that there's not one in their area. So in that situation, what should patients like me or anyone outside of the Chicago area do in that case? Should they see their pediatric cardiologist still? Should they? Is there a third option besides seeing a congenital cardiologist?
Well, the recommendations, they have these guidelines for ACHD, and they have recommendations about how often an ACHD person needs to see an ACHD provider. And the recommendations and the guidelines that are made by, the American Heart Association, American College of Cardiology, are that if you have complex heart disease, you should be seeing an ACHD provider at least once a year. And that number changes based on the severity of your heart disease. If you have moderate severity or simple CHD, they have different parameters as to when you should see them. So it might be that you have one kind of hybrid model is that you have an adult cardiologist, because if you don't have an ACHD provider, you just don't. So you have an adult cardiologist for many visits, but once a year, then if you have complex congenital heart disease, you then go to see an adult congenital provider, even if it's far away, even if you have to make kind of a trek, because it's important, because they know things and they have the type of training that adult cardiologists just don't have. What I will say, if there's anything positive that's come out of coronavirus in the United States from a medical perspective, that is the advent of a huge increase in telemedicine. That has completely changed the game for most of us in terms of having to ramp up our telemedicine efforts. Mm-hmm. And so I do think that moving forward, there will be a lot more opportunity for telemedicine to be infused into the adult cardiology space, where there can be more of a partnership between adult cardiologists and adult congenital specialists in areas where there are not adult congenital specialists. And hopefully, that is something that's true moving forward. But I do believe that the hybrid approach for people who don't have access to ACHD specialists may be the best approach. Having no care is a bad idea. Seeing the ACHD specialist whenever I can is a bad idea without having a kind of a planned visit. So kind of planning it to see them at least once a year if you have complex disease, or less so if you have less complex disease, in conjunction with an adult cardiologist is probably the best hybrid approach for now.
So to build off of that, so if a child continues to see their pediatric cardiologist, how do you ensure that they receive the appropriate transition education despite seeing the same provider?
Yeah, that is an excellent question. I will say that when we embarked on our transition journey, this started out as a pilot project at our hospital. The people who were the most resistant to our transition program were the pediatric cardiologists. And so because you have to bring up a bunch of uncomfortable topics that people didn't want to talk about. And so not all, as you stated, not all places have transition. I guess getting on websites and knowing what transition topics are and then discussing those topics, like the iHeart Change or the app that we're developing, having those questions in place and then bringing those questions to the pediatric cardiologist is a very good idea for places who do not have transition programs. And so just I'm going to give you a brief overview about some of the things that a transition education program includes. And I had a list here so I wouldn't forget. So understanding your disease name and surgeries, what are emergency signs and symptoms for you, understanding why you take your meds, what are potential side effects, what happens if you stop taking them, what in the world is endocarditis, why do you care if I go to the dentist, what are your activity restrictions, so are you somebody who's not allowed to exercise or restricted from certain exercises, understanding how to ask for help if you're not doing well in school, because you're unable to, because you have a learning disability that's not diagnosed. There's a pretty decent number of individuals with CHD that have undiagnosed learning disabilities. Learning about future family planning, learning about birth control, learning about the need for lifelong care, and then certainly recognizing how stressful this all can be, and knowing to assess for anxiety and depression. There's a study that was done that showed that upwards of 50% of patients with congenital heart disease had some degree of anxiety and or depression, the majority of which were untreated.
Wow.
And so we actually just did a study as well here. And when we looked at younger children, because we thought, well, that's what's happening in adults, what about for younger kids? And it turns out that there are also a large number of younger children who are on anxiety and depression medication with CHD. That and some patients, depending on how vigilant, I guess, your pediatrician is or your pediatric cardiologist is to screen for this, depends on whether or not you find it. You can't find something you didn't look for the most part.
Yeah.
And so, so knowing those topics that we educate on and saying, oh, these are what's important, and then using some of the websites to help inform you, and then coming to the pediatric cardiologist with those topics is a really good idea. The other thing I wanted to say is for most pediatric cardiologists, I would say that the thing that they complained most about talking about was sex and birth control. They were unhappy about these topics. And so, yeah, they were unhappy that we were making them talk about these things. And so, because they're cardiologists, right? And so what we ended up doing, the American College of Obstetrics and Gynecology, or the ACOG, actually has formal recommendations for all females between the ages of 13 to 15. And that is that they all should have their initial visit with a gynecologist between those ages, whether or not you have CHD, period.
Wow.
Because there are a lot of undiagnosed abnormalities surrounding menarche or getting your period, and things that people don't know, or what's abnormal, what's normal, what birth control can I be on, is this safe? And a lot of these questions are kind of a combination discussion between the pediatric cardiologist and the gynecologist. And if those questions don't, and those discussions don't begin early, it can be bad, because then there can be an oops type situation where the teenager then ends up pregnant because you didn't have these conversations, and they have a very significant lesion, and that can put their life at risk. And that's the worst case scenario.
Yeah. Wow.
I would have never thought about any of that. That's very educational.
You also
It's
mentioned,
like thus transition education. So yes.
Yeah.
Well,
Yes.
I mean, I think that, and another reason that I'm so excited that we have you on, and we have both you and Jennifer, is just, I think when you think of the transition process, at least for me as a parent of a very young heart patient, that's not even what I think about on the spectrum of transitioning out. My thought is moving her to adult care. Can she draw up her aspirin? I didn't even think to bring in gynecology or anything like that as a part of the transition process. So this is all really important information. And I mean, wow. I'm sorry.
Yeah.
I'm learning a lot.
One other thing I'll say, and this has actually been novel to our pediatric cardiologists as well. So we also, in addition to saying, are you having appropriate programs or IEPs if you need them for school and things of this nature. If you have an undiagnosed learning disability, it might not just be because the kid is lazy or whatever. It may be because they actually are having a real hard time doing the work. But beyond that, understanding lifelong trajectory. So that's more than just, oh, I see, I was born and I have this disease for the rest of my life. Got it. It's palliated, or it's fixed now, or it's sort of fixed now, or we don't like to use the word fixed. there's a bunch of different things in that space, but understanding what jobs you can have is hugely important to this process. Understanding like what does college look like for you is hugely important to this process. So we had a child or a teenager who came in whose desire in life was to be a welder. That was what they wanted to be, and they had an ICD. They had a defibrillator device, and no one ever said to them, actually, that's not going to work for you. And so when we had this discussion with them, like, you need to talk to your pediatric cardiologist about that, because that seems like a less good option for your lifetime goal there, because it seems like it's probably not going to be feasible. It came as a huge shock to this person who had no idea that this was not possible. And so even having that discussion, all of that is important in kind of your lifelong trajectory, and that should all happen kind of in transition education.
Wow.
Dr. Lopez, you also mentioned earlier that insurance was an important thing to talk about during the process of transition. How does insurance change for patients as they turn 18 or beyond, and how might it impact the kind of care they can receive?
I will say that it is astounding to me how little is known about this by not only providers but also by parents, because it's such an important topic. So there are three general camps here. One is I don't have insurance. One is I have public insurance or governmental insurance, Medicaid or CHIP, and then the third is I have private insurance. All right, these are the three kind of general insurance buckets, or lack thereof. So if you have CHIP insurance, or it's a specific subset of state Medicaid insurance, you have that insurance until the day you turn 18. Once you turn 18, it's over. No more insurance. If you have Medicaid insurance that is not CHIP but Medicaid, and again, this is all state by state. So Medicaid and CHIP are state regulated; they're not federally doled out; they are state regulated. Then you have insurance until the day you turn 19 through your 18th year. If you have private insurance and you are on your parents' insurance, you have insurance. You have the ability, because of the Affordable Care Act and the provisions of the Affordable Care Act, some of which included not being able to not allow someone to have insurance because of a pre-existing condition, and the other one is being able to stay in your parents' insurance until you're 26. Well, that's true if you have private insurance. And so if you have private insurance, you are currently able to stay on your parents' insurance until you're 26. But I think, as I'm sure everyone is aware, that that the Affordable Care Act is currently in the courts in terms of determining its constitutionality. And so depending on the outcome of that will depend on whether or not patients with private insurance can stay on their parents' insurance until they're 26. Other insurances include predatory insurances. So there are people who say, "Oh, look, this is a super low deductible. You don't have to pay very much monthly, and it's insurance. Look, it's insurance." Some of the predatory insurances were done away with the Affordable Care Act, meaning insurances that act like they're insurance but they don't cover much, and that we call those predatory insurances. And so the Affordable Care Act put a lot of stopgaps on those. And some of those have now gone away with some of the repealing of the Affordable Care Act. And so that is something that people need to be aware of as well, is not all insurances are created equal. And furthermore, the Affordable Care Act marketplace insurance and other insurances in general are not accepted at all heart centers. They are not accepted at all ACHD centers. And so understanding beforehand whether or not this ACHD accredited center or this ACHD provider accepts that particular type of insurance is critically important. For some reason, CHD patients tend to have lower rates of disability insurance and SSI insurance compared to other chronic diseases for some reason. So those tend to be harder to qualify for, and a lot of CHD patients don't fall into that qualification category for whatever reason. I don't know if it's just on our end that we're not doing right, or if they just don't qualify because they don't have enough disability, or what people term disability. And so lastly, this is part of the reason why we actually talk about your trajectory in life in this space of transition, because it's so important that you retain insurance for your care. The understanding that you need a job in this country to do that is part of the reason why that discussion is so important.
Wow.
So are there any medications that are cause for concern when taken over a long time?
You mean medications that are common for congenital heart disease patients to take?
Yes. Sorry. Yeah, so I have a little example that's written over here. So one of them was, for example, my daughter has been on enalapril and digoxin since she was a baby. As she grows into adulthood, should she be having conversations about not just the effectiveness of the medication, but how long she's been taking it?
So
I'm gonna flip this slide. I'm sorry.
most medications that people that we use, this is going to sound really crazy, but many medications that we use in congenital heart disease are off-label use. In other words, these are medications that were approved for adults. And so we say, oh, how interesting. And then we kind of retrofit it for our needs because there's not as much data on children, because doing drug trials in children is much, much harder than doing them in adults. And so that being said, the majority of the medications that we use have proven to be safe over time. I mean, there are some medications that probably require some other follow-up. So for example, if you've been on Lasix for a very, very long time, that can affect longer term, it can affect hearing, it can affect bone fragility. And so people will tend to look at some of those things longer term. But in general, most of the medications that we use have been, even if they're off-label use, have been used for so long that we think that they're relatively safe for long-term use in children as well, as a general statement. There are newer ones that we're learning about, but in general, that's probably true.
Dr. Lopez, you touched on earlier the importance of reproductive health. As an adult with complex CHD, what kind of questions should I consider asking my OBGYN if I consider conceiving in the future? And how should I involve my cardiologist in the discussion of birth control or other things related to reproductive health?
So there has to be a relationship between the cardiologist and the OB/gynecologist in these decisions, because not all gynecologists are trained to care for or to give birth control recommendations to CHD patients.
Right.
Not all cardiologists feel comfortable giving recommendations on birth control methods, and so it's like a marriage between the two in order for this to work. I will say that a novel model that is kind of up and coming in the CHD world in terms of conceiving as an individual with congenital heart disease is there are now these kind of combo clinics between maternal fetal medicine, which is high risk OB, and congenital heart disease. So there are some adult congenital heart providers that will work in conjunction with maternal fetal medicine doctors in the same space, which is what we do here at Texas Children's. We have clinics specifically for adult congenital heart disease patients who want to get pregnant. This is a newer model that we have here, and I think a lot of places around the country are also gathering steam in a lot of different places, because we have found that you can safely have many women, a large majority with congenital heart disease, can safely have a baby, even though they have congenital heart disease, but it requires a high level of expertise. And so the marriage between the two, usually you have to have both involved, not just one, to have this be successful, either in a pregnancy situation or in a birth control recommendation situation. So a conversation with both is critically important.
Dr. Lopez, you've hit a bit already on one of the other topics that I'm very passionate about, especially when it comes to the CHD world, and that's mental health. So knowing, you've already kind of shared that there are a lot of CHD patients that are at a higher risk for depression and anxiety and ADHD. Do you have any recommendations as far as going about that? I've already learned a lot about the correlation now between, your OBGYN and your CHD cardiologist. Is there that type of connection as well between, if someone's taking the medications for their mental health as well, and how that ties in with their congenital heart defects?
Well, we've come a long way in congenital heart disease efforts, both in the pediatric space and the adult space. We used to think we were awesome when patients were surviving, and then we thought we did a great job and then we were done. And now we have learned that that is not true. There's a lot of other spaces that we need to improve upon. And one of those was neurocognitive deficits. And one of those is mental health. And those two things actually a lot of times go hand in hand. A lot of adult congenital heart disease survivors have challenges with executive functioning. And as we spoke about earlier, executive functioning, it comes from the frontal lobe, which is the last part of the brain that develops. The one that doesn't develop until you're in your mid-20s or even later if you have congenital heart disease in some cases. But executive functioning are things that allow you to do things like multitasking, deciding what thing is more important to do first, kind of higher level decision making. And if you have a challenge with a neurocognitive challenge that it goes somewhat unrecognized, making those decisions can be harder for you, and that can then spiral into feelings of anxiety about making decisions and or depression surrounding not being able to make decisions. So those two things I think are intimately linked. The other thing I'll say is that unfortunately not a lot of screening occurs in this space as it pertains to mental health. I do think that is hopefully changing over time. I think people are recognizing that this is more and more of an issue, and we are recognizing it earlier and earlier. So there are now individuals who specialize, psychiatrists who specialize in congenital heart disease. We have one here. She's a cardiac psychiatrist, and her specialty is patients with congenital heart disease.
Wow.
So we will partner with sometimes with a cardiac psychiatrist to say, hey, this patient seems really concerning, or they have some issues with anxiety that they're unable to manage. A lot of times, like I said, it goes unrecognized. And part of that is because in this space, if transition is not a part of the process, you don't get to uncover these things because the parents just a lot of times will speak and no one even knows what the kid is thinking. And so, or what the teenager is thinking. And so it is something that as we evolve as a field and say, oh, transition is critically important because it helps us to understand mental health, because it helps us to understand long-term trajectory, because it helps us to understand what jobs you can have. And that helps us to understand insurance and being able to have a baby and et cetera, et cetera, et cetera. It's kind of one thing rolls into the other. And so we are doing more work in that space. And like I said, we have done a study not only in congenital heart disease patients, but also in arrhythmia patients, looking to see about anxiety and depression. And one of the fascinating findings from that was, there are a lot of kids in the 4 to 9 year old space that are actually diagnosed with anxiety and depression, which is shocking.
Wow.
It's shocking to me, which can largely go unrecognized if not assessed for. And secondly, a lot of people assume that the only patients that have issues with anxiety and depression are those with severe disease.
Mm-hmm.
It turns out that in our study, we showed that if you have simple congenital heart disease, as opposed to complex, like an ASD or a VSD, your likelihood of having anxiety and depression is 3 times higher or 3.5 times higher than the average population.
Wow.
So it's shocking. I was floored by this, but that is what we found. I don't know, and that's again one group of individuals here at Texas Children's, but we looked at over 1,000 patients for this information, and so it's pretty. It took me aback a little bit to say, oh my word, we've been saying it's just a complex people this whole time. Oops.
Yeah.
Like we probably need to be doing more work in all of our patients, because having apparently any degree of congenital heart disease can be stressful to a patient, because even though me as a provider, I'm like, oh, it's a simple lesion. That is not how it feels to the patient.
Yeah.
It does not feel simple to them. And so that is not something that we have probably recognized as significantly previously. And I think it's something that's going to be becoming more to the limelight, if you will, as the years go on and as we do more work in this space. There are a lot of people interested in this space, which is helpful. That's great.
Yeah. Wow.
Wow as well. I'm absorbing everything that you're saying, and I just, so I know that we have one last question on our set list of questions. I'm actually going to skip past that because we touched on it a little bit earlier about what do you do if you move, and kind of finding a new doctor. So I'm going to move over to, we only have about 5 minutes left, you guys. We want to make sure that we're respectful of everybody's time. But we do have a couple of, if there are still time questions, and I wanted to touch on a few of them. So the first one is,
I'm sorry to interject for 1 second. One quick second. For those individuals who, for whom independence is unlikely to be achieved, teenagers
yes.
for whom independence is unlikely to be achieved, I just want to put this out there because it's often not touched on, unfortunately. Understanding the terms durable power of attorney, medical power of attorney, and Hippa release. Those are 3 important terms. I'm not going to go into them right now, but understanding those terms, what those terms mean, and how those terms affect your ability as a provider to continue to make decisions on behalf of your 18-year-old and above, who is unlikely to make to be living independently.
Mhm.
Those 3 terms are critically important in the transition space for those that will not be independent from their parents. That's it. Sorry, I had to get that in there.
No, don't be sorry at all. That's actually on the if there's still time questions.
Oh,
That's one of the questions. Can actually let me skip the one that I was going to ask you, and I'll just skip over to that if you want to elaborate more. I'd love to give you the opportunity to do that because that is really important. So the question that we have on our list for that was, my child is developmentally delayed. Will he need additional assistance and services as he ages? What might transition look like for him if he doesn't have the skills to be independent?
So in those scenarios where they are not independent, we have something that's called the parent track in our own program here. And in that track, we do teach about durable power of attorney. And this is what allows you to allows your child to authorize you to manage their financial affairs, either in the immediate future or should they become mentally or physically unable to do so. It would also authorize you to pay bills, apply for Social Security, government benefits, etc. Medical power of attorney allows your child to authorize you to make medical decisions if he or she is unable to do so, or if it is deemed that they are unable to do so by testing. There can be testing that's done that says this person cannot make independent decisions on their own, and so you have to actually get signed a medical power of attorney. It's an actual legal document that has to be signed. It requires like a notary and all this other stuff. And then the Hippa release is one that requires Hippa, as you know, is the Health Insurance Portability and Accountability Act. And it's basically what allows for patient protection of information. So if you don't have a Hippa release and your child turns 18, then you're actually not technically allowed to access their data as a parent. And so being able to sign a Hippa release allows you to continue to access your child's data and authorize your doctors are authorized to then share diagnoses and treatment options with you, which is obviously a different situation if you don't have that. Even if someone is disabled or potentially deemed unable to make decisions, some of that has to be kind of medically and legally differentiated.
Is the Hippa release something that is good forever once it's signed, or is it good for a period of time and needs to be renewed?
I don't think it needs to be renewed if you're at one center, unless there's potentially a clinical change in the patient or something, and they want to change it. But I think if you move to a different center, or if you're letting yourself in another ER, I don't believe I'm unclear is a better answer if that carries over into other institutions.
Okay.
Man, Dr. Lopez, I wish we had like multiple hours to be able to pick your great brain and just like be able to share because I feel like I know that I've learned so much of just about the transition process and how it's developing. I know when Ren was like 7 months old and I was like, so let's talk about when he starts to become an adult. So it's definitely something that is a big deal. So just knowing that there are, institutions like Texas Children's in Houston that are developing these processes and, is absolutely amazing. And I know by the time, our kiddos are up there and in that age range, it'll only be even further advanced. And that's almost relieving to know and hear. So just to kind of wrap up, because we are at that time and we want to be, respectful of your time, are there any last kind of bits of advice for being your own best advocate as you transition that you would give?
So I'll say that for the parents, listening, there are certain things that predict poor ability to make it to adult care.
Mm-hmm.
Some of those things include not making your pediatric appointments. That's a predictor for not making it to adult care.
Okay.
Not meeting the ACHD provider beforehand, or having an identified ACHD provider beforehand is a predictor to not making it to adult care.
Mm-hmm.
Not having insurance is an obvious predictor. And so educating yourself on those particular topics would be very, very helpful. Understanding who is an ACHD expert versus an adult cardiologist who may not be an ACHD expert. And then understanding your congenital heart disease and understanding what constitutes an emergency for you. If you're unable to, if you land yourself in the emergency room and you're unable to articulate what you have, and they take your shirt off and they see a scar on your chest, it's extremely intimidating to the providers in the ER. But it also could mean a big trouble for you if you're unable to articulate what your congenital heart disease lesion is.
Yeah. Wow.
So that basic, what we call it, we call it a 3-sentence summary. And it's knowing the name of your disease, knowing what surgeries you've had, and knowing what constitutes an emergency for you. Those are really, really critically important in this space. And so I would just encourage individuals to familiarize yourself with some of these topics and say, to help in this space, and to say transition is normal, it is necessary. You shouldn't feel weird about giving your teenager more independence. This is all a part of the process, and they have to learn these skills, these transition skills, to be able to be successful adults. So becoming a great cheerleader.
I love that. I love that. We become the cheerleaders. I really want to thank both of you ladies for joining us and for using the platform that we have to share such important information. Dr. Lopez, I know that you probably noticed that Crystal is taking notes. We're going to have a lot of follow-up questions for you. So we will be in contact. But again, this has all just been, I feel like for the most part, when we have these, we have the discussion, we send over our questions. We kind of get a general feel for what our answers are going to be. But this was really kind of just a really educational hour. At least I know for me, I'm going to go back and rewatch this probably 3 times and just absorb everything that you and Jennifer have shared, because the ACHD world is so, so important. And I feel like sometimes it gets a little put on the back burner, and what you guys are doing over in Houston is just absolutely incredible. So we want to thank you again for all of the research and the work that you're putting in. And Jennifer, thank you as well for everything that you do for Conquering CHD. And if y'all have any closing comments, please say them now. But other than that, we have hit our hour.
Oh, is she muted?
Oh, Jen, are you muted?
Oh, no, I don't think so.
Oh, there we go. Okay.
I just wanted to thank you as well, Dr. Lopez, for joining us today and being so engaged in our conversations prior to tonight as well.
Yes.
It was very helpful in creating a good program for tonight. And I did just want to also mention to the other patients and the parents out there watching, please just remind your child or yourself that even if you're feeling good, it's really important to still see your doctor, that there's no such thing as being fixed. So that's my 2 cents.
Thank you so much for sharing your experience too, Jennifer, because it's so critically important. People who have not had the opportunity to have a transition process and who are just immediately transferred, it's a very jarring and unsettling experience. And so I applaud the ability you've been able to make the jump successfully at 33, which is insane.
Yeah.
Thank you for your advocacy, because part of this is advocacy and understanding why this process is important. We have had to fight for this program because most educational programs don't make a lot of money, honest, but it's so important to the outcomes of our patients that we really hope that individuals can can at the very least utilize what's available on the web for transition to try to help them in this space.
Well, ladies, again, thank you all. I hope that you all have a good night. Dr. Lopez, we will be in touch. Thank you. Everybody, thank you for joining us. We appreciate it. Have a nice night. We'll talk to y'all later.
Thank you.
Bye.
Bye.